Hi, I'm Earl Silverman, Editor-in-Chief of the journal Rheumatology, and I'd like to introduce you to a new feature of the journal Rheumatology. This is an interview with the senior author of one of the papers I've selected in my editor's highlights. This will be a new monthly feature and will appear as a full-length interview with a video on our website and YouTube, and a portion of it will be part of my monthly podcast, the audio version only. So I'd like to begin with my selection for the month of January 2021. I live in the past, it's okay. The article is entitled Improving Hydroxychloroquine Dosing and Toxicity Screening at a Tertiary Ambulatory Center, a Quality Improvement Initiative, and is by Koppikar and colleagues from the Division of Rheumatology, Women's College Hospital, University of Toronto. And today I'm pleased to be speaking with Dr. Natasha Gakhal, who is a senior author of the paper. Natasha, I want to thank you for taking the time to speak to me and to our listeners about your very topical article about using a quality improvement initiative to improve adherence to guidelines for the use of hydroxychloroquine.
Thank you for inviting me.
No, my pleasure, absolutely. So let's begin. First question is, could you briefly review the design, rationale, and highlight the important findings of your article?
Yeah, so thank you for choosing the paper for this new feature of the podcast. I'm excited to talk about our study. As a background, there are guidelines from the American Association of Ophthalmology and the British Society of Rheumatology focusing on recommendations for appropriate hydroxychloroquine dosing and toxicity monitoring. However, despite these guidelines, there is data to show that there is poor adherence to safe and effective dosing of hydroxychloroquine. There have been several studies that report between 35 and 55% of patients are still receiving doses in excess of the recommendation maximum. And though this is decreasing over time, there's evidence that at least 30% of patients are still receiving doses above the recommendations. The studies looking at adherence to retinopathy screening are better, showing approximately 80 to 85% adherence in some studies. However, in other studies, this was as low as 50%. So with that background in mind, the objective of our study was to characterize the frequency of appropriate weight-based hydroxychloroquine dosing and retinal screening in our clinics at Women's College Hospital here in Toronto, Ontario, Canada. The second objective was to develop quality improvement interventions aimed at improving these rates. One of the things with all quality improvement work, even if you have a strong literature base to show the frequency or rate of events you are studying, you always want to study the baseline data locally in your institution or practice to confirm that there is a gap that needs to be addressed. This step is important because any intervention you will implement will be in that local environment. So we undertook a retrospective chart review to obtain some baseline data on how we prescribe hydroxychloroquine in our practice, how often we document weight, and how often we document retinal screening. Our primary aim was to increase the percentage of patients who were appropriately dosed on hydroxychloroquine, and our secondary aim was to increase the percentage of documented retinal screening. Our preliminary retrospective chart review revealed that our patients were prescribed hydroxychloroquine based on their weight about 30% of the time, and we were documenting retinal screening about 59% of the time. We used quality improvement methodology, in particular Plan, Do, Study, Act cycles or PDSA cycles to implement 3 interventions. We first implemented a paper-based hydroxychloroquine dosing chart that was available in all the exam rooms to facilitate prescribing. Our second intervention was adding weight scales to patient rooms to facilitate patients being weighed. And our third intervention was introducing an EMR forced function where we were required to document the weight, and a dose would auto-populate based on that weight. And if there was no weight documented in the EMR, you would not be able to print off a prescription for hydroxychloroquine. After these simple interventions, we had improved appropriate hydroxychloroquine dosing from 30% to 89%, and we improved retinal screening documentation by approximately 33%.
Very impressive. Yeah. So the one thing that you addressed at the beginning, and it struck me that appropriate dosing was only in 30% of the people. And I think you addressed that it was mainly too high, but how frequently were you seeing low dosing?
Yeah, so this question goes back to how we defined appropriate dosing of hydroxychloroquine for the study. In the initial retrospective chart review, we defined the percentage of patients with appropriate hydroxychloroquine dosing as less than or equal to 5 milligrams per kilogram of actual body weight, as documented in the chart. And if the patient's weight was not documented in the EMR, they were classified as inappropriately dosed. So based on that definition, this would not take into account people who were dosed below the maximum acceptable dose. We were looking for overdosed people because we're worried about toxicity. We were capturing patients who were overdosed or those who did not have a weight documented in the chart, because without a weight, you can't confirm the correct dose. Now, there may be reasonable scenarios where a rheumatologist purposely orders a dose above the recommended maximum based on the clinical presentation or diagnosis, and therefore this would have also been flagged as inappropriately dosed, but may not actually be inappropriate.
Okay, good. So you showed an increase in documented retinal screening. Do you think it actually altered actual retinal screening? I know it's a hypothetical because you don't know who really gets screened without a letter from an optometrist or ophthalmologist.
Yeah, so this is a common question that comes up in quality improvement research, and a lot of quality improvement projects are focused on improving documentation because documentation is important, particularly medically, legally. If it's not documented, essentially it didn't happen. And in this project, we actually didn't have a specific intervention that was targeted, that was targeting an improvement in retinal screening. So our suspicion is that the implementation of all the change ideas for appropriate hydroxychloroquine dosing served as a reminder to the clinician during the patient encounters to not only ask if they had completed their retinal screening or ask for that documentation, but also to document that conversation. So the likelihood is that the actual number of patients being screened for retinopathy probably didn't increase, but the clinicians were better at asking about the screening and documenting that conversation.
Okay, thank you. Your interventions were simple, as you said. What do you think was the most important thing?
So there were a total of 3 interventions that we implemented during the course of the study. And in the paper, you can see that out of the 3, having weight scales in the room didn't actually significantly improve appropriate prescribing of hydroxychloroquine. The most intervention was likely the first one, which was the paper-based hydroxychloroquine dosing charts in the exam rooms, followed by the EMR forced function for inputting weight with subsequent auto-dosing based on that weight. The paper-based hydroxychloroquine dosing charts improved appropriate prescriptions from 30% to 68%, and the EMR forced function increased it to a further 89%. Now, initially, this was surprising to us, as we thought that the EMR forced function would have been the most significant intervention. However, the paper-based hydroxychloroquine dosing charts were in every exam room, were very eye-catching, were very colorful, were very easy to read, and were placed right by the computer so we could easily see it when we would prescribe the medication. They were also present for several months prior to the implementation of the EMR forced function, so we really came to rely on that paper dosing chart in our day-to-day clinical practice.
It's interesting, I think it's just reminding people. I mean, if you know somebody in weight, I think my grandson, who's in grade 2 now, could do the math.
Yeah.
So 5 times a weight, he's a smart kid though.
Exactly.
So last question, and I think that's important. We all need to be reminded constantly about doing things. My last question, do you have any data one way or the other that these changes are persistable? I guess the force function, if it's there, you haven't taken it out. So maybe I just shot myself in the foot with that.
Yeah. So that's a great question. And in quality improvement research, this is always the ultimate indicator of a successful study. You not only want to show that you've improved from baseline, but that but you also want to show that that improvement has been sustained over time. So we don't officially have any data to show if the improvement has been sustained over time. But like you alluded to, our EMR force function does not allow us currently to order a hydroxychloroquine prescription currently if there's no weight entered into the EMR in the last 12 months. And there's no way to bypass that, the entry of the weight, because I think we've all tried. So, and you can print off a hydroxychloroquine, and you can't print off a hydroxychloroquine prescription if you don't enter a weight. So it's a bit of a hard stop. So we think that the improvement has been sustained over time. However, the interesting thing is you can enter a weight and then choose a different dose than what's provided based on their weight. So you can override the EMR's recommendation, but only after you've entered a weight. And from a clinical point of view, you do always want to have the ability to override, as there will be clinical scenarios where you want to do something different than the recommendations, but you want to make it difficult for people to do that.
Good. Thank you. Excellent. Thank you. Do you have any further comments you want to, for our audience, or?
Yeah, so I think the study highlights a couple of things that's important to keep in mind. The first is we can think we're doing a good job, but until we actually do audits of our practice, we don't actually know. And like you said, appropriate dosing of hydroxychloroquine was only seen at baseline in 30% of our population. And that seems surprising, but that's what the data showed. So you don't actually know what your rates are until you actually study them. And the second thing that this paper highlights is how simple interventions that don't require a lot of time or cost can be highly effective and improve the delivery of evidence-based care.
Good. But I guess we'll see 20 years from now if this type of intervention actually decreases the retinopathy.
That's right.
At least you will. I don't think I'll be practicing medicine then. Well, on that somber note, I want to thank Natasha for taking time to speak to me, and to our viewers and everybody who's listening. Please read the full-length article, Improving Hydroxychloroquine Dosing and Toxicity Screening in the Tertiary Ambulatory Care Center, a quality improvement issue by Dr. Gakhal and her colleagues, and it's available at jroom.org. And we'd love to hear your comments about the article or anything else on Twitter at jroom, or by email at manuscripts@jroom.com. So I want to thank you for everybody for listening, and I hope you will join us next month when I will speak to the senior author of one of the picks from February of 2021. Bye for now.